So I'm gonna raise a question, I guess, and just challenge the concept on a. So I guess I made the argument yesterday that shorter. There are advantages to shorter, but there's also disadvantages to shorter. And one of the questions, I guess, for both of you, so in Egypt, you talked about the training of healthcare workers to provide the care, but one of the things that response-guided therapy adds is a significant layer of complexity. It sounds simple to say, well, if it's negative, it's not that hard to figure out. If it's negative at 2, you only treat for 3 weeks, and if it's not negative at 2, you continue for 12. That sounds really simple, but that's for people that are familiar with treating hepatitis C. When you have to change therapy and you're trying to roll it out on the scale that you've done in Egypt, I'm actually amazed that you've been able to find enough healthcare workers to provide the care. So
can I go first?
Sure.
Because I think it's I think the concept is a good one. I'm not saying that 2 days is the best or 7 days or whatever it could be, and the viral load could be 500 or 1,000 but something low, whatever that is, and whatever is easiest to. If you have a litmus test quickly, that will tell you plus or minus 1,000. That would be great in Egypt. Nobody's developed that yet, but we're getting close. So I think that the way it would happen in Egypt, people, because they do get a lot of attrition, a lot of people don't come back. So there's a great motivator here. You only give them 2 pills or 3 pills, and you send them off, take the 3 pills, come back, measure the viral load. While they're waiting in the doctor's office, 1 hour test or less, you then give them the rest of the bottles for 3 more weeks, if they're below a certain level. If not, you give them the other combination. So I think that's the way it's going to operate.
But if they don't come back, you've got resistant virus.
Not necessarily. 3 days is not going to cause resistant virus. You know that all the clinical trials, 2 days or 3 is not going to cause resistant virus. So that's how we do clinical trials, by the way. With nukes, we are allowed to go 7 days, even 14 days. With non-nukes, we can go 3 days.
Well, I think shorter duration would be
Sure.
much better for us, but I think we need better diagnostics as well. That's a huge issue because we're still having a problem with PCRs, rolling out PCRs in all centers, and the contamination and the numbers of cases, and this is a big issue. We're looking at Gene Expert now, but unfortunately it's very, very costly, and it's not FDA approved yet, as you know. And the other problem is that if you have the small machine, it takes only 1 sample, 4 samples, 16 samples. So even the high throughput machines are very, very expensive and might be difficult. Maybe with decreasing the price with something like this in a closed system, no contamination, that might be a solution. It might be helpful. Doesn't need training, doesn't need technicians, doesn't need sophisticated lab equipment. So that might be very useful.
Manal, I was really curious to hear more about the stepwise testing program that you have in mind. I'm never quite sure what proportion of people who have hepatitis C in Egypt are aware of their status. That's number one. And then what is the burden on the individual to pay for testing so that they can sign on to the website that you described? And then, given a large number of people who have Hep C, what are some of the possible screening recommendations that are being considered?
Well, we talked about this several times. You know that no more than 10% of the population know that they are infected with hepatitis C, and that's the maximum number. So we decided to start with the easier populations and the easier to reach populations. And those are the family members of patients who are being treated in the center. So if you ask them to bring back their families to be tested, and we're having a sort of a deal with some of the big labs to give us sort of free coupons for patients to be tested in their labs. And that's one of the things that we're doing, and we're working also with other philanthropic organizations to provide us with free testing for some of the patients. So they don't even have to come to the center. You just give the patient, if the number of the family, if he has 5 members of the family, you give him 5 of those, and he goes and tests and comes back and registers whoever is infected. And the second group we're thinking on phase 1, that's all in phase 1, are the healthcare providers. We have a very high risk of infection in the healthcare providers, whether physicians or nurses, and I think those are accessible. And we need to treat them because they are, first of all, it affects their performance, and secondly, because they are at the risk of transmitting infections inside because of the needle stick injuries and everything. So we're starting with those, and then the next step is going to be for patients undergoing interventions in hospitals. And that's easy, because they're already coming for surgery or coming for an intervention inside the hospital, and part of the routine lab testing is just blood picture, liver functions, and we're going to include just HCV testing or antibody testing. But of course, we'd be very happy if we have better diagnostics at a cheaper price and point-of-care testing for population-based screening, because eventually we have lots and lots of NGOs now in Egypt. After the presidential endeavor, everybody's running, they want to do something in this program, and they want to work alone. So we're trying to bring all those people on board through its same system, but we have to give them the tools for diagnosis, so to be able to roll out the program also in remote areas.
Right, forgive me, I don't have a clinical background, but I just wanted to ask, in your study with the short duration treatments and your Chinese patients, would it be fair to say that the majority of them would be likely to have the favorable IL-28B CC ally?
I don't have the data with me. It will be presented at ASLD if you're going, but it doesn't. I don't think it. We haven't totally analyzed all the characteristics in terms of IL levels and IL type and all that stuff. This is all going to be a secondary analysis. So some of it will be presented at the ASLD, including the viral load and many other cytokines and so on.
Hi, my question's for Dr. El Sayed. I, first of all, love the energy with which you present, and I think that that is so key to have those types of voices and passion and sort of no shit, no nonsense kind of, dialogue on these topics, and I think that they help drive to change. I was interested in your presentation. This is the first time I've heard about Egypt's process, but at 2006 you mentioned the establishment of a national committee to control viral hepatitis. I was a bit curious about how close government was to the establishment of that. Was that something they asked for? Who made up that committee? And also, how did you ensure that government listened to what you said needed to happen?
Well, actually, the National Committee was established by the Minister of Health, and we are part of the Ministry of Health. But we are independent in our financial infrastructure, our decisions, and more or less have a sort of independency from the government, but we work inside, we are part of the government. And all our liver units are part of the Ministry of Health hospitals. So we go and visit Ministry of Health hospitals and we choose a place. We have a sort of a description of what a unit should look like, how many rooms, the pharmacy place, etc. And then we organize this place and set up a sort of a unit inside one of the big hospitals that's affiliated to the Ministry of Health. But now we are also including university hospitals. We're including also the private sector hospitals. So we're trying to bring more people on board. So we are, at the end of the day, part of the Ministry of Health. We are government. But they're listening. They are listening because we are, more or less, we're academics. We're all experienced. All the members of the committee are experts. So I think they are listening. They have been listening. We actually have also a very good voice in the media. So the media listen to us and not to the ministry and not to the government.
Just to add to Manal, I mean, I was born in Egypt, so I know a little bit about Egypt, although I haven't lived in there for many years. But basically, and I visited Egypt many times, we're talking about almost every family in Egypt affected by this virus. Every family. So this is a major tragedy, a plague of sorts. So the government is very sensitive to treatment, and so this is something that is every family knows about hepatitis C.
I just wonder, with the infection control issues in Egypt, how much work is being done to change people's perceptions about injectable medications? Is there a social media campaign to say, hey, you don't need those injections at all?
Yeah, that's what we're working on now with WHO, because this is what the pilot supports coming for Egypt for injection safety program. So we're rolling out now the assessment, the baseline assessment for the injection safety program, and then we're going out with an awareness campaign for both viral hepatitis and particularly for injection safety. And it's going to have everything, all elements within, and it's fully under the support of the WHO.
I've recently visited your country, just 3 weeks ago, was surprised of the number of forced preparations
Yeah.
shown. The nicest one was Gratisovir, very good name, cost nothing. And then was a Nucleobuvir and so on.
Lots of names.
Huh?
Lots of names. I cannot
Lots
remember
of
them.
names, yeah. The point is, we have a sizable Egyptian community in Vienna, and they travel to Egypt and buy it without any problems, no registration required, nothing. So the question is this system which was shown last year, and you showed it again with this three-dimensional identification tags, a working system, or is just a system which could be applied but is not required? I hope you understand my question.
Yeah.
And the third question I have is, I mean, the problem is very big in Lower Egypt, the Nile Delta.
Yeah.
But I understood that in Upper Egypt, close to the Aswan Dam, and then further on to Sudan, there's not so much hepatitis C. Is there a reason for this?
It's the reason for this is the bilharziasis, of course, schistosomiasis, because it was highly prevalent in the Lower Egypt, on the northern part of Egypt and Delta, around the Nile. And most of the infections came through the injections for anti-schistosomal therapy in the 40s, 50s, 60s. It's not now, it's no more. They were glass syringes at that time, and they were giving the tartar emetic on regular basis to patients infected with schistosomiasis, so that's how the transmission started. But the transmission was sustained through the community with practices, of course, like informal injections, unsafe injections, medical procedures that are not safe. Our system is very, very strict about patients. However, now with the generics are sold out in pharmacies. So people just go and buy them from pharmacies. And the previous minister, we have a new minister now, the previous minister was a bit strict about prescriptions. They had to provide prescriptions. Each pharmacy, for whoever is coming to dispense the medication, make sure that he's coming from a specialist physician or a hepatologist. But there was a sort of a consortium from pharmacists against the ministry and against the government, just to make sure that this is not required anymore, because all the drugs are sold over the counter, so why do this with this special medication? So I think the system, there are some leaks within pharmacies, so still, especially in rural areas, it is sold in pharmacies, the generic drugs, for free, for everybody, without prescriptions. Without prescriptions, and even in Cairo, some of the pharmacies are selling them. But inside our centers, it's a very strict system for dispensing medications, because this is a government expenses. The government is paying for the medication.
First of all, Dr. Shanazi, I just want to really echo that I really also hope that our pharma partners and industry will get behind that kind of study that really can sort of change the trajectory of how quickly we can influence treatment access. Dr. El-Sayed, I'm very curious in the Egyptian context with the privileging of injections for treatment. Is there stigma around injection for drug use, for street drug use? What's the difference there? Because I mean, here, you know, I would hazard to say that the stigma around injection is perhaps keeping people from becoming infected, you know, in the large numbers. But in a population where everybody privileges that mode of transit, which arguably is a very refined mode of transit, what is, if any, is there a stigma around injection drug use for street drugs?
Yeah, definitely there is. We do have a stigma around injecting drug users. We do have some special programs run by the UN as well for injecting drug users. And I've had several meetings with them trying to get some of the injecting drug users within our program to be treated. And I think we're rolling this. However, even the previous minister of health, was not happy about this at all. He said, I have nothing to do with injecting drug users. And that was really strange, because they can also transmit infections. I had a patient who was pregnant. She had acute severe hepatitis B, and she was worried about her baby, and she discovered after marriage that her husband was an injecting drug user, and he refused to be screened. But there are special programs for them, and I think it's very important that the unprivileged populations or the vulnerable groups, like the injecting drug users, the incarcerated, we should have special programs for those. We're getting some resistance from the government, but I think we have to do this eventually.
Just wanted to expand on the last question, really. In the general population, because there's such high awareness about hepatitis C, because it's so prevalent, Is there stigma around hepatitis C like we see in countries like the US and Canada?
I think it's getting better now. There was definitely stigma about hepatitis C, and even some of the companies were not employing people who are hep C positive. Some of the big corporates, they were not employing them. You know that still they are being prevented from traveling to work in Arab countries like Emirates and Saudi Arabia, and based on antibody testing, even if they are cured. And that's one of the things we spoke to Minister of Foreign Affairs about, that they have to speak to them. If the patient is cured, he will remain antibody positive maybe for his lifetime. So why just prevent him from working elsewhere? So they are being stigmatized, and we're trying to remove this kind of stigma. I think it's getting better now with the new drugs, and people understand that they can be treated. And one of the things we're trying to do is give them some certificates to tell them that they are cured. And just this is a kind of incentive to bring back the patients to report SVRs as well.